Okay, so we start the meeting. Good morning, all. Welcome back to Saturday Club morning meeting. And today we have a very interesting topic and a new guest speaker for us. The topic is obstructive sleep apnea and overview. And for that, we have Dr. Rakesh Gupta from USA. He's medical director, PrimaCare Sleep Center at Somerset, Massachusetts, USA. To formally introduce him, he is a Baroda Medical College alumni, and he belongs to the class of 1981. And thanks to Dr. Kiran Bhai, his classmate, for arranging this topic. And Dr. Rakesh Bhai, you seem to be very popular in your class. So many of my classmates, contacted me and say that they are happy to have Rakesh here today. He's done his fellowship in pulmonary and critical care, University of Connecticut, sleep medicine at Mayo Clinic, Rochester, MN. And current practice is a full-time sleep medicine specialist. His clinical interests are sleep apnea, providing support tools to make CPAP therapy successful. And his research contribution has been a landmark study in 2001 on post-operative complications in patients with sleep apnea and impact of prior CPAP therapy. So with this brief introduction, I request Dr. Rakesh Gupta to start his talk. You will speak for about 40-45 minutes, and we'll keep 10-15 minutes for interaction later on. So over to you, Dr. Rakesh.
Okay, thank you so much. So first of all, this is a Zoom meeting, so I have arranged a welcome for myself, and I'm going to garland myself to welcome me. So here you go. That's what I play with all day long, my masks. Okay. So I'm going to share my screen. Okay. All right, so this is a sleep talk, and falling asleep in this talk is allowed and often beneficial. So what you're going to see on almost every day, some media headline has something related to sleep. And I just have 3 headlines up from within last few weeks. Long COVID is popular. I get patients who say I have long COVID and it's not sleep apnea. And I say, COVID just brought that to your attention. You've had sleep apnea causing fatigue for a long time. So yeah, there are a lot of things that are getting called long COVID that are pre-existing sleep disorders. Sleep apnea is linked to cognitive problems, even in otherwise healthy men. We're going to hear a lot of these consequences, and we'll have a section on that during this talk too. So it's a fairly common thing that most people see in practice. So and this is not an easy show of hands, but I'm just going to say, most of you might have met these type of patients who have felt tired. It's a very common complaint in clinical practice, or snoring that keeps a spouse awake, or waking up choking, or going to different specialists for different problems. The common one is going to a urologist for enlarged prostate because they're going to bathroom too many times at night. Or see a lot of advertisements on TV about all these migraine medications. Wonder how many of them get tested for sleep apnea. Resistant hypertension is a very common clinical problem. And one of my passionate topics was postoperative complications. Common thing on postoperative floors, but we give it different names for different complications. And sleep apnea could often be at the root of those. So that side of sets the clinical setting. This is what we deal with day in and day out. So this is going to be sort of the outline of the talk that will go over a basic understanding of what is sleep apnea, look at its prevalence, pathophysiology, clinical features, how we evaluate sleep apnea with different tests, what are the consequences of untreated sleep apnea. And that's going to be sort of primarily the focus. Treatment of sleep apnea is not the focus of this talk, because otherwise nothing can be covered. So I just took care of the treatment in first minute, right? with my garland. So, and then we want to have enough time for questions. So first, what is sleep apnea? And it's just a category of one of the abnormal breathing patterns in sleep. So when we look at international classification of sleep disorders, there is a range of breathing disorders, but the most common one is obstructive sleep apnea, which is the first one. And others are different types of central sleep apnea or different types of hypoventilation syndromes, and just simple snoring without disordered breathing. So those are different breathing disorders. But today's talk is purely on obstructive sleep apnea. I'm not going to go anywhere near the other breathing disorders. So what is sleep apnea? Conceptually, it is a repeated upper airway collapse due to relaxation of the upper airway dilator muscles. So during sleep, all muscles relax, including the muscles that keep the upper airway open. And the most important one is the tongue muscle or genioglossus. So when that happens, there is reduction in the tidal volume. Each breath is shallower, smaller, and because of the resistance in upper airway, diaphragm has to produce extra negative pressure. And that can be measured as esophageal pressure, or PES, as we can see in this graph. So what this graph is showing is, these are the breaths. Breathe in, breathe out, that's the flow. So going up is inspiration. That's normal. And the way we breathe is with spontaneous inspiration, there is about a -2 to -5 intrathoracic pressure that draws the air in or suctions the air in. And then expiration is passive, brings the mouth pressure back to 0. But if the upper airway is obstructed, so in this side, there is a normal breath followed by stopped breathing, which means the upper airway is blocked. So that's the obstructed airway. And there is respiratory effort against the obstructed airway. So there is a very high negative esophageal pressure, which tells us how bad the effort is. And that negative esophageal pressure has gone to like -50, -60. I have some other sample graphs where there's -100. That's a very strong negative pressure. And because of that no airflow, there is desaturation. So oxygen saturation, that's the bottom graph, drops. That causes an arousal. So this apnea is terminated by an arousal response. The arousal activates all the muscles. So the body may jerk, but tongue muscles are activated, palate muscles are activated. So the airway opens up. Take a few breaths. Oxygen saturation comes up. Esophageal pressure is back to normal. So you're not requiring extra effort to breathe. And the brain is happy, goes back to sleep. Muscles relax again. Throat closes again. Cycle repeats, right? So that's what sleep apnea is in concept. And then we have these different definitions of different types of respiratory events. So the word apnea means a complete cessation of airflow. And on sleep studies, we'll count them as apnea if this airflow cessation is more than 10 seconds. Now that apnea will be classified as obstructive apnea if there is continuing respiratory effort, like we saw on the previous slide. So on this slide, we have sample sleep studies here, and the EEG, these are the different channels recorded on a polysomnography. So we have EEG, EOG or electrooculogram is used for eye movement, that's used for finding REM sleep. Muscle tone again is chin muscle tone is again used to stage REM sleep. Snoring is detected using a microphone. There is a thermal airflow, meaning that measures the breathing through mouth by temperature change. Nasal pressure flow that measures the breathing through the nose. Chest and abdomen movements are measured using belts around the chest and abdomen. And normal movement of the chest and abdomen is in sync. Both expand together and come back together. But when you're breathing against an occluded airway, there is this paradoxical motion. Chest moves out, abdomen moves in, and vice versa. So that paradoxical motion is one of the signatures of obstructive sleep apnea. If there is no respiratory effort, then this becomes central sleep apnea, and this patient is having actually Cheyne-Stokes breathing, what we commonly see with heart failure patients. Now, if there is a reduced airflow, not a complete cessation, but it's reduced by at least 30% compared to the baseline, then this is called hypopnea or reduced breathing. There is criteria. We cannot call all reduced breathing hypopnea. There has to be associated a 3% oxygen saturation drop. So this graph is too small, but you can see the oxygen saturation line going down. There has been a change from 93 to 90%. So that drop in breathing can be counted as hypopnea. The other criteria that allows us to count it as hypopnea would be an EEG arousal. So you can see that the EEG has become a little faster, and you can't really see the waveforms here. Then there is this category called RERA, or respiratory effort related arousal. So as the name suggests, these breaths have become flat instead of normal rounded breaths. Normal breaths are nice and rounded. Flattening of the breathing is due to airway obstruction. And here there is the depiction of how the shape of the breath changes when the upper airway is partially obstructed. So here the oxygen saturation has not dropped, but there is a arousal, and the change in amplitude is less than 30%. If it was more than 30%, we would have called it a hypopnea. So for example, a 20% change in amplitude of breathing with an EEG arousal will be called RERA, or respiratory effort related arousal. These definitions have gone through so many changes. what was hypopnea before is RERA. What was RERA before is now hypopnea. So when we read literature from 20 years ago, 10 years ago, and current, we have to be aware of changes in definitions that have happened. But they pretty much convey the same pathophysiology. So after looking at all those events, we count them on a sleep study and come up with a summary at the end of the test. And you count all of the apneas and hypopneas and divide it by the total sleep time. That gives you an apnea-hypopnea index. And normal would be less than 5 events an hour. We will only talk about apnea-hypopnea index because, as I said, definitions have changed. This RDI was more important before, but a lot of those RERAs now have become incorporated in the hypopnea. So this RDI is of less significance now. So by AHI, 5 to 14 events per hour is mild sleep apnea, 15 to 29 is moderate sleep apnea, and more than 30 is severe sleep apnea. Now that severe sleep apnea is a big category because more than 100 is also severe sleep apnea. And they're not same things. There is this other terminology that gets used called respiratory event index. That is just to emphasize that home testing produces a different way of counting things. Because there is no EEG record in a home test, we don't have actual sleep time. So the denominator is total monitoring time rather than the total sleep time, which would sometimes underestimate AHI. So for example, if there were 100 events total and total monitoring time was 10 hours, your AHI comes out 10. However, if EEG was available and we said out of 10 hours, 5 hours was sleep, 5 hours was awake, then 100 divided by 5 hours of sleep time would have given AHI of 20 per hour of sleep time. So we just have to be aware that even though we use it as an AHI, it is a different number and can underestimate sleep apnea. There are a lot of other parameters that are calculated and reported on a sleep study. I think a few oxygen saturation measures are very helpful, particularly the mean saturation, lowest saturation. We don't really, that captures most of the information. So these other time under 90% or oxygen desaturation index, those are more used when it's not a sleep study and only an oximetry is available. And I'm not going to go into the other measurements that are made that are not related to breathing. So there is more information available on polysomnographic sleep studies. Home testing only records breathing. So those arousal index, leg movement, that is not available on a home study. So having understood these different events, what these words mean, let's now come down to the criteria, how we make a diagnosis of sleep apnea. This is, okay, these criteria are by American Academy of Sleep Medicine, and these are designed for the American healthcare system. Doesn't mean they should be applied verbatim to other situations. So especially the criteria B. So out of the diagnostic criteria, first category is some clinical information. Either patient has symptoms of sleepiness or fatigue or something, some insomnia, or patient has witnessed apneas, gasping, choking, or patient has a comorbidity that has a very high correlation with sleep apnea, such as hypertension, coronary artery disease, stroke, CHF, atrial fibrillation, diabetes. So some clinical scenario has to be there. And then either a polysomnography or OCST is the other name for home sleep testing, out of center sleep testing, shows that AHI is 5 or more. So for our healthcare system, both A and B are required. So some kind of a sleep study is required to make a diagnosis of sleep apnea. Otherwise, treatment is not covered by insurance companies. Now, if the sleep study shows 15 or more events, which means it's moderate to severe sleep apnea, then it can be diagnosed as sleep apnea syndrome without clinical information. So patient does not have to be symptomatic. For mild sleep apnea on polysomnography, we cannot diagnose a clinical syndrome. There has to be some symptoms to call it a clinical syndrome. So that's what sleep apnea is. And it's really a bad time for both. Early morning for you, late evening for us. So let's try to do the best, move on to prevalence. Everywhere I look, I see sleep apnea. Yeah, it's like jaundice eye, everything is yellow. Everywhere I see actually sleep apnea. It is a highly prevalent condition. So if anybody looks, they will find sleep apnea. So this is one of the recent articles. And basically, I want to focus on this introduction, the very first line there. Approximately 1 billion of the world's population of 7.3 billion people between the age 30 and 70 are estimated to have the most common type of sleep disorder breathing, obstructive sleep apnea. And the prevalence is rising in all countries. So which other disorder has such wide prevalence? Okay, so this is a very common problem. And China and India make it to the top, but these are the absolute numbers. Just because of the big population, so the absolute number comes out high. In terms of percentage prevalences, these percentages are going to jump around depending on the publication you read, anywhere between 5% to 30%. So whatever we choose to believe will be the prevalence. But on an average, I think 10 to 15% is a reasonable guess for most. And the increase in obesity everywhere, all over the world, is gradually increasing the prevalence of sleep apnea. So when people have looked at studies done in early 2000, then in 2010, and then closer to 2020, there is a linear increase in sleep apnea prevalence everywhere. India is no exception. So these are some actual numbers where India is about 13% for all sleep apnea and about 5.5% for moderate to severe sleep apnea. That's prevalence in the population. So very high number. Comparatively, USA moderate to severe sleep apnea is 13%. Some of it has to do with just the methods used, diagnostic criteria used, diagnostic testing used. So not all research studies are equivalent. Right, so once we go to the pathophysiology, I think this cartoon becomes very valid. And we may feel like what somebody or Rakesh must have discovered that shift key, right? So let's see this. First, we have to orient ourselves to the anatomy. And when we talk of the upper airway, it starts in the nose and goes up to the glottis or larynx. The nose is a rigid portion. It can have variable congestion, but there is a rigid support to it. The pharynx is the collapsible part of the airway. And then below glottis, the tracheal ring cartilages give it support. So it becomes rigid again. The middle segment is collapsible. And right behind the palate, that part is called retropalatal. Right behind the tongue is called retroglossal. That is the area of interest. Okay. And here comes my shift key. And sounds very simple. So try to understand this. The upper airway is like a model, Starling resistor model. So this is how you classify its properties, where the middle portion is collapsible and the two sides are more rigid. And this collapsible pressure, whether it's going to stay open or closed, depends on how much pressure is compressing the outside of the airway, and then what muscles or how active the dilator muscles are that's pulling it open. So right. So this is how you watch a cooking show and then you just say too complicated. So we're just going to outsource the upper airway physiology to Mayo Clinic right now. Let's hope this works. So I'm going to play this YouTube video. It's 1 minute.
When we breathe, air travels down the throat, through the windpipe and into the lungs. The narrowest part of that pathway is in the back of the throat. When we're awake, muscles keep that opening relatively wide. But when we
can't see the video.
Relax,
you can't?
That narrows the
We
opening.
can't see the video.
Okay, so then we have to skip that.
Yeah.
Air passing through may cause the throat to vibrate. That causes snoring. Obviously, many people experience this.
Oh, I think I know what happened. Is it opens in a different screen that is not shared?
Yes.
Yeah. Okay. So trying to make it easy, not have to explain this diagram. But it was graphically representing the upper airway. Let me see if I can get to that. So on this share screen, am I able to choose what screen to share?
Yes, you can do that. Minimize this screen, what you are looking at. And on your desktop, when you on the Zoom, when you press on share, click on the share, you will see different tabs. So one of them would be your YouTube. So then you can click on that and it will be shared. Yeah,
but in some people, the
yes.
throat closes so
Now we can
much.
see.
Now you can see.
Travels down the throat, through the windpipe and into the lungs. The narrowest part of that pathway is in the back of the throat. When we're awake, muscles keep that opening relatively wide. But when we sleep, those muscles relax. That narrows the opening. The air passing through may cause the throat to vibrate. That causes snoring. Obviously, many people experience this. But in some people, the throat closes so much that enough air doesn't get through to the lungs. When this happens, the brain gets a message to wake up. The brain quickly activates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This only takes a few seconds. You may not even know you've awakened, but this process may happen over and over, hundreds of times, all night long. You may never get into the deep, restful stage of sleep. As a result, you may feel exhausted when you wake up and feel sleepy all day. Many mistakes and serious accidents are caused by sleep deprivation.
Okay, so back to where we are. So mainly, we look at sleep apnea as anatomic and physiologic problem. Anatomically, people with smaller throat, and we can guess that using the Mallampati classification of throat.
You can put it on the slideshow again.
Yeah,
Yeah.
I just did. Yeah. So when we look in the throat and we can see all the structures and we can see the posterior pharyngeal wall, that's what normal is. Most of our sleep apnea patients will fall in class 3 and class 4. So when you look at the pharyngeal area, what keeps it open versus what keeps it closed, the balance shifts in sleep apnea patients. So at baseline, that already that pharyngeal lumen is smaller, going towards 0, so that during sleep, when these muscles relax, the balance tilts completely and the lumen closes. So that's what sleep apnea does in terms of balancing different forces. That's how sleep apnea happens. So let's look at the clinical features, how this pathophysiology or repetitive closure of airway and arousals and desaturations, what symptoms it produces. So we can have symptoms caused directly by the upper airway obstruction, and the most common one is going to be loud snoring, witnessed apnea by somebody else, or the patient themselves complaining of having woken up gasping, choking, or snoring. Then you have consequences of fragmented sleep, such as sleepiness, fatigue, low energy. A common complaint is foggy brain. Wake up in the morning, but just don't feel alert, fully alert. At night, they're waking up too many times, sometimes have difficulty going back to sleep. Cognitive performance is reduced. There are attention problems. Some patients get diagnosed with ADD, memory problems, cognitive decline. And then there are some other symptoms that are commonly present, like morning headaches, nocturia. Often these patients end up in different specialist office. So that would be neurology office, urology, ENT, seeing patients for sore throat, heartburns, going to GI, night sweats going to endocrine, and irritable short temper. Now we see them all. So now, which patient is most likely to have sleep apnea? We can, other than symptoms, we can look at some risk factors, and those risk factors predispose patients to having sleep apnea. So obesity is the most common risk factor. However, this becomes stereotype, and only obese patients then get referred for evaluation. The truth is that 1/3 of sleep apnea patients are not obese. So translation, 2/3 are obese, which means it is major risk factor. But if we just look for that, we will miss 1/3 of the patients. Male sex, testosterone does something to the breathing. Progesterone, we all know, is a respiratory stimulant, stabilizes the breathing. So males have more sleep apnea. However, after menopause, females do catch up. And as we get older, our muscle function declines. So all the upper airway muscles are not as good. In addition, anything that makes the upper airway small, like retrognathia, micrognathia, will do it. Positive family history, often the facial structure is going to run in family history, even the way the muscles function run in family, genetically. Sedentary lifestyle affects muscle function, affects the tongue structure, the amount of fat in the tongue. There are several genetic syndromes that have a smaller airway. In children, adenoids and tonsils make the airway small. And then there are certain endocrine syndromes that can also affect the upper airway function. But if you just focus on the top three, obesity and older age, we don't want to discriminate by gender, but obesity and older age, middle age typically is what is the biggest risk factor. So what do we, on physical exam, what will we commonly see? And this is not going to be an exhaustive list, but these are two patients that were recently seen, and I took their permission to take their pictures. Nobody can identify them anyway. But they're obese, they have a high BMI, their oropharynx shows very marked crowding with a Mallampati class 4. This actually is a throat while it plays. So while I'm asking him to say I can see some uvula in there. Otherwise, it's a class 4 throat. And then this patient has retrognathia. Okay? So most of my exam would be focused on the upper airway, just looking inside the throat. See how big the tongue is and has marks from the teeth on the side because of the size. Nose may show some obstruction or congestion, but that is not the site of pathophysiology. It may exacerbate the problem, but that's not the cause of sleep apnea. And often patients have a short and thick neck. So once we have identified what type of patients or what symptoms, then we have to test them to confirm the diagnosis of sleep apnea. And we have a few ways of doing that. So objective testing is the bottom part, but other than taking a detailed history, to make it more efficient, patients can have screening questionnaires, and a stop bank questionnaire is commonly used. It measures snoring, tiredness, observed apneas, and hypertension. Those alone are enough, and you add some objective measures to that. BMI more than 35, age more than 90, neck circumference more than about 17 inches, and male gender. And if the score is 3 or more, there is an increased chance of sleep apnea. Those patients should be sent for sleep evaluation or sleep studies. So how do we objectively test? It has been a standard of care. If I go back about 15 years, all we had was this gold standard polysomnography. We did have oximetry always, but in US system, because that is not acceptable diagnostic test to pay for CPAP treatment or any treatment, we don't utilize it as much. We have to go to a sleep study, but it is a very good test overnight, and I'll show you some examples. I don't think it should be ignored in resource poor settings. I think overnight oximetry can be a very helpful tool. Okay? So when we look at sleep studies, there is either a home sleep study and a in-lab sleep study. In-lab sleep study records a lot of parameters, but when the question is about breathing disorder, then recording just breathing should be more than enough in majority of the circumstances. So home sleep apnea test works out fine as a starting point. So here is what a normal test looks like. This panel shows the oxygen saturation all night, and it's a nice steady oxygen saturation, staying well above the 90 level. And this is a 4-minute snapshot. Green is snoring. There is a snore with every breath. Oxygen saturation is 95 to 96. And these are the breaths, nice sharp breaths around. and they look peak because of the compression, but there is no flow limitation here. And the respiratory thoracic belt, that's the chest movement that shows us the effort, where we can say it would be either obstructive or central problem. So this is what normal sleep study looks like. This is somebody with very severe sleep apnea. So you can see their oxygen saturation starts okay when they're awake, about 92, 93%. But then during sleep, it has gone down, way down. And right now this cursor is here, and that's the 4 minutes snapshot of breathing. And there is this apnea. Between these two lines is 30 seconds. So this apnea is about 1.5 minutes and showing a drop in oxygen saturation down to 44% or so. I think that's a typo. Lowest saturation was 44. So, but with a very high AHI. Now here is an example of another, but this is a polysomnography done in the sleep lab. And this is a split night study where first half of the night is diagnostic testing. And during the second half, CPAP was administered. So first half, you can see the same phenomena, a lot of frequent drops in oxygen saturation. And on the breathing channels, you can see how the breathing stops and starts and how the saturation drops. And then if you look at the second part of it, which is on the CPAP, and here you can see the CPAP pressure being titrated gradually up, and it has reached a pressure of 10. And at the pressure of 10, we can see that the breathing is very stable. Oxygen saturation is very stable, 95, 96. And this red is REM sleep. So we see that there was no REM sleep in the first half of the night, but there is a big REM sleep towards the end. So we're seeing a rebound REM sleep. This patient was deprived of REM sleep for a while. So I mentioned, I'm going to pay a little more attention to oximetry here because it is cheap, convenient. And this is one of the devices available on the market. I use this one in my practice. For severe sleep apnea, this is a very good test. You can't miss it. For milder disease, yes, it may not detect it, and some patients may need a full sleep study. So here are some examples of oximetry recorded from that. And we don't have to go through the numbers. We just look at the pattern, eyeball pattern, and say, this is what normal looks like. This is severe sleep, moderate to severe sleep apnea. See the big drops in the oxygen saturation. With that type of pattern, in 1 second, we can say, yes, this patient has sleep apnea and needs treatment. We don't really need further testing on these two. Same thing here. Now, we look at this one. That looks suspicious. I am more than 80, 90% confident this is sleep apnea. We could go to treatment, but if we require further confirmation, depends on clinical history. If the clinical history is very high probability of sleep apnea, this could be taken together with that to say we can go on to treatment. Otherwise, we do a sleep study. So this is somebody who tried to do that, and I don't know what happened, but we only have about 1 hour of recording. Is this 1 hour recording enough? You know, this is more than enough recording. This 1 hour just gave the diagnosis. I don't need further testing if the system did not come in the way. So putting it all together, you have to have symptoms, you have to look at the risk factors, you do an objective test to confirm the diagnosis of sleep apnea. And like I said, oximetry alone could be adequate in 50 to 70% of the patients. Now, there is not a lot of differential diagnosis. This is not one of those pulmonary problems or neurological problems where we have to go through. We're really dealing with mainly sleepiness, fatigue, snoring. How much differential diagnosis we can do for snoring? So what we have to look at is other causes of fatigue. And the one thing that I find in my patients is there is never one cause of fatigue. And I have some real cases at the end that I don't think we'll have time to read through them, how these all come together. But a patient could have, I could count them 5 causes of fatigue, and I still tell them, okay, but sleep apnea is still in the place, so we still need to do it. Just because you do night shift work, you only get 4 hours sleep, doesn't mean you cannot have sleep apnea. Okay, so just because you have one explanation for sleepiness doesn't mean you should stop. So let's look at if we've diagnosed sleep apnea, if we do not treat it, what will happen? Why should we treat sleep apnea? Okay. And the way I tell my patients is, if we don't treat sleep apnea, sleep is necessary for restoring every single cell in the body. So every single cell is going to complain in some way or other, or we can take it to the organ level to say every organ system is going to complain in one way or other. So this list will sort of give some of the common disorders that are where obstructive sleep apnea either contributes to the causation of the disorder, or makes the disorder more severe, or makes the disorder progress faster. And these are all the day-to-day common bread and butter diagnosis. Driving accidents are 5 times more common. Typically, we all are going to decline with age. Every single organ system is going to decline in functional capacity, but the rate of decline is faster with bad sleep. Okay? So what was supposed to happen at age 70 will happen at age 50 or 60. So in sleep apnea patients, those heart attacks will come at an earlier age. Otherwise, they may have come 10 years later. So strokes, headaches, dementia, I'm not going to read through every single thing here. These are pretty much common, but I will point out that many of my patients go to urology first for nocturia. They go to men's health clinic, get their testosterone checked, and get on testosterone injections for sexual dysfunction. Then they come to me somehow. Resistant hypertension is a big category, very low-hanging fruit. That's where we can make a big difference. So cardiovascular system is kind of the holy grail. Everybody is worried about the heart. So I'll worry about the heart a little more here. Where are we running with the time? 11:20.
Yeah, so I would request you to wrap up in next 5 minutes.
Yeah, next 5 minutes.
5 minutes for correction. Yeah.
Okay, so I think rather than going through all these mechanisms of how sleep apnea causes damage, one of the unique mechanisms, all of this sympathetic overactivation, inflammation, those are some common mechanisms, but something unique to sleep apnea is the negative intrathoracic pressure. Like we said on the very first slide, how negative esophageal pressure is -40, -50. That produces a huge afterload on the heart. And this is another slide worth looking at, where there is a femoral artery catheter monitoring blood pressure. So there is intraarterial during sleep, and you can see the normal breaths and then hypopnea, and then normal breath and hypopnea. And you can see how the blood pressure spikes and then comes back down, and the spike is going up to 200. So if this patient had an AHI of 100 an hour, you're going to have spikes of blood pressure to 200 that many times in 1 hour. How many times in one night? Okay, that's a huge load. So you see how the sleep apnea damages the cardiovascular system. And here's the prevalence of sleep apnea in different cardiovascular disorders. Just take an average of 50% and you'll be right. So lot of sleep apnea patients have, a lot of cardiovascular patients have sleep apnea. Almost 50% of them will have sleep apnea. And this is an observational study to say what is the impact of sleep apnea on survival. And the top red line is patients with severe sleep apnea, and controls are in green here at the bottom. So you can see how the fatal cardiovascular events are higher in the severe sleep apnea group compared to the other groups. And when the sleep apnea patients are treated with CPAP, and that's the blue line here, they behave almost similar to normal population, general population without sleep apnea. So that's how much benefit you see with CPAP, regular CPAP treatment. Okay. So I was planning to skip the treatment part anyway. So take home messages here that it's a very highly prevalent disorder. You look for it, you'll find it. You're going to see it everywhere. And it's there in the differential diagnosis of all of the common symptoms. And if for busy practitioners, all you have to do is ask these two questions maybe. Are you satisfied with your sleep? Do you snore? If the answer is yes, then you go further. Or you just use a stop bank questionnaire. You have to treat it as if it is a cardiovascular risk factor. Patient comes to you, always check their cholesterol. Why not also ask 2 sleep questions? Okay. So there are several clinical scenarios where even without symptoms, you should, even if the patient says, I'm fine, I sleep fine, like resistant hypertension, they should be checked for sleep apnea. And as far as objective testing, often the lack of availability of sleep study is a barrier. I would say oximetry is so easy, it will identify almost all severe disease. And those are the patients who are going to have long-term consequences. So I think that can be utilized. That oximeter I was showing you, in US, we can buy it for about $200. And that's a consumer level device. It works very well. I use it in my practice. So in summary, like one word explanation of what does sleep apnea do to your body? Faster aging. Okay. And we may get to that slide in a minute. So questions?
Yeah, Dr. Rakesh, if you can go back to a couple of slides back and speak about for a minute about treatment part, because this is a heterogeneous audience here. They would like to know in brief the treatment part. Then we'll take the questions.
Okay. So these are the available treatment modalities. You can do conservative treatment such as weight loss. Sleep apnea is worse in supine position, so avoiding being on the sides will reduce it. Keeping the head elevated with a couple of pillows or putting blocks under the head or putting a wedge under the mattress would help a little. Most people have already used this type of position treatment naturally without even conscious awareness. They have adopted those things. Now, one area which should be more used is tongue exercises. There's a fancy name for it, but that's one of the slides at the end that I thought I would get to. The gold standard is positive airway pressure therapy, CPAP therapy, which is the continuous positive airway pressure. It just, the way I explain it to patients, you got a flat tire in the back of your throat. So when the tongue collapses into the throat, that's like a flat tire, and you can inflate it with compressed air. So that's what the CPAP does. Okay. Now, oral appliance is this type of device. So here is the effect of CPAP. It's inflating the airway. You can see at different levels of pressure, the airway enlarges. The oral appliance pushes the lower jaw forward. That brings the tongue forward and gives extra space, but it puts a strain on the TMJ joint. And there are other surgical treatments which are the least effective out of all. The upcoming treatment is hypoglossal nerve stimulation. The brand name is Inspire. The effectiveness is about similar to oral appliances. And these are about 50 to 70% effective, whereas CPAP is 95% effective. Okay, so that's how much difference there is in the treatment options.
Thank you, Dr. Rakesh. That was excellent overview of the subject, and as you said, very common. And when we discussed among ourselves as to what areas should we focus, I had recommended to him that we should focus on how not to miss the diagnosis of sleep apnea, and you've brilliantly done that. Now we look at some questions in the chat box. One is from Dr. Ganesh. You may please stop the screen sharing now, Dr. Rakesh.
Yes. Okay.
He says that in your second slide, you told post-operative patients SpO2 dropping up to 70%. In later slide, SpO2 dropping to 45% also. By itself, obstructive sleep apnea can cause death. We keep hearing people dying while in sleep. I think that's the same question Dr. Sant was asking you before we started the program. Yes, Dr. Rakesh.
So sleep apnea causes death similar to can cholesterol, hyperlipidemia cause death, can hypertension cause death? That would be the same answer, how sleep apnea causes death. But there is one other way the sleep apnea causes death is motor vehicle accidents. That's more short term. And these post-operative complications, if a patient develops heart attack post-operatively, we have a name for it, we all understand it. And we might just scratch our head to say, his stress test was negative, everything was negative. Why did he develop a heart attack? Why did he develop a stroke? Why did he start bleeding? The surgeon did a good job tying all the bleeders, but when the blood pressure spikes to 220, it can open up some bleeders. So sleep apnea may be the root cause of some of these complications, and obviously post-operative deaths have happened. We often attribute it to some known consequence, but the sleep apnea may be the underlying cause.
Right. And Dr. Hemansan wants to know more about the equipment you use for measuring only pulse oximeter, SpO2 at night.
So that is, those are called overnight oximeters or continuous oxygen monitors. If I do a Google search, say the one I'm showing is a Velue brand, WELLUE.
Okay.
That's the brand, but there are so many of them. And now consumer level, there are rings available that you can wear instead of. I don't like the rings because if it is not a proper size, it gives artifacts. But there are so many different consumer devices now available.
Right. Dr. Sant is also asking about when do you use BiPAP?
I think that's a little bit more
Technical.
specialized. But one common scenario is difficulty exhaling on CPAP. So exhaling against a pressure is sometimes uncomfortable. Some of those patients may be better off on BiPAP. There are other indications of BiPAP for patients who have hypoventilation. Their PCO2 levels are high. So then we are using BiPAP not just to open the upper airway, but also to increase their tidal volume with each breath.
Rakesh, Satish bhai, my question was how to get the graphical record of oximetry. So does this value give the graphical record? Because pulse oximeter is available.
Yes. Let me see if I can share the whole screen.
Before you do that, can we take up the remaining one question?
Oh, okay.
One, I think there are two compliments from your classmate, Dr. Sanjay and Dr. Kiran are very happy to listen to your talk, and they are congratulating you for that. And Dr. Rajiv is asking cardiovascular outcome benefit with treatment. Has there been any study on outcome regarding after the treatment for your obstructive apnea? Obstructive apnea.
I actually have a whole 1 hour lecture separately on cardiovascular and criticizing all the published studies. So my simple answer is, if New England Journal publishes a study, that does not mean it's a good study. And right now, I have a very good slide. I can share that with you.
Yes, yes.
So back in 70s, streptokinase was proven ineffective for myocardial infarction. That was, I think, 1970. And then GISSI study came in 1987 or something. And I have a slide for that. So the sample size went from 570 to 1100 something. And then streptokinase was highly effective. And we know how things turned out after that. So we are at that stage for sleep medicine where there's so many of these studies showing, oh, CPAP treatment has not been shown to have cardiovascular benefit. I don't want to use bad words, but it's bad science. I'm convinced it has benefit.
Okay.
No, the problem is that when you treat sleep apnea, there has to be some threshold as well, right? For you to see benefit, you have to kind of use it for at least minimum for what, 4 hours or 5 hours or whatever the cutoff threshold may be.
There is no real cutoff, Rajiv. The way I tell the patients, if the insurance companies didn't come in the way, 1 hour of treatment is better than 0, and 3 hours of treatment is better than 1 hour, and then 6 hours of treatment is better than 3 hours. So it is a continuum. Obviously, the maximum benefit is when you use it during the whole sleep time. But any percentage of sleep time you use CPAP, you still benefit.
Satish bhai,
Yes.
taking more of your time, for 6 years you see in 2017 without any risk factor got any coronary event. And today I will be pleading with everybody, if you suspect a obstructed sleep apnea, please get a sleep study done and please use CPAP.
I think that's the message Dr. Rakesh has been trying to drive through to all of us, that it's a very common condition, should be easily diagnosed and should be easily treated. So that was the message. Dr. Rakesh, do you still want to show that message quickly on your screen?
How to take graphics, Satish bhai?
Yes,
Of
yeah.
oximetry.
He has actually shown an equipment where I think it would be like a screen on which you can actually play the graph. That is what I understand.
No person is asleep, Satish bhai. In the morning, he has to
Dr.
get up and
Rakesh.
get the graph.
So that like in our wearable devices, like our smartwatch, we can see how much we have walked steps, how much calories we have spent, how much hiking we have done. All that is shown in the smart map. So I think similar equipment he's showing. Yes, Dr. Rakesh, please. And regarding availability of that, wearable, that I don't know about. I mean, some other physicians may throw some light on that, whether it's available in India also.
Yeah, I think it's available through Amazon. I haven't checked India site, but here I can get it in a few days. You can buy this on Amazon.
So
There is a
what Dr. Hemant is asking is whether how do we see the whole night's graph? I mean, is it available in this device?
yeah.
Okay.
So you can have an app on the phone, or there is desktop software. I give out this device to my patients to take home, and then I use a desktop software called that's where I have taken all these snapshots. So I just download the data to the desktop, but the same can be done on the phone itself. You don't need the desktop.
Right. So thank you for Any other comments? Now you can stop the screen sharing. Yeah. Any other comments or question? We can spend about a minute or two. Already we have overshot the time by 7 minutes, but still, I mean, this is an interesting subject. And if somebody has any question, it's okay to have it. So no questions, no comments now. Thank you, Dr. Rakesh, for excellent, very informative talk. And the interaction was also very useful. So thank you all. We meet next Saturday morning again. Thank you. We end the session here.